All right. Hi, everybody. Welcome to the first session of our PCOS webinar series. My name is Tracy Stack. I'm one of the nurse practitioners here at Seattle Reproductive Medicine. I'm actually here at the Spokane location. First off, all of us here at SRM just want to say thanks for joining us today. We are offering all of these presentations every Thursday this month to provide some information on polycystic ovarian syndrome, and also to let you know about a new program that we have recently launched called the PCOS Wellness Program. So for our first presentation today, Anne and I are going to talk about what that wellness program is, and then also just give an overview of PCOS and the health implications that come along with it. So if there are any questions that come up throughout our talk, feel free to utilize the chat feature on Zoom, and you can direct your questions either to Anne or myself. And we're going to try to focus on questions that pertain specifically to what we're talking about today. So kind of the general overview and then the health risks. So all of the other topics will probably be covered in subsequent presentations. So we'll try to focus on the questions that pertain to today's talk. So now with that, I'll turn the floor over to Anne to introduce herself, and then she's going to get us started.
Thanks so much, Tracy. And again, thanks to all of you for coming. I know this is a fairly brief talk. We want to be respectful of your time. We're going to try and keep it to that half hour, and we do want to have time for questions. So the slides are going to go pretty fast, and please feel free to message us. We'll probably hold on answering questions till the end. And again, we have a lot to talk about at the later session. So I know you're going to have a lot more detail further on. Today, we mostly want to talk about why we started this wellness program and what does it mean when we talk about the overview and the risks of PCOS. Next slide, please. So basically, our wellness program is for individuals that have PCOS, and they may or may not be trying to get pregnant. A lot of people first really try to address their PCOS when it becomes a fertility issue, but PCOS is a lifespan condition. And so we want to help people who are, of course, seeking pregnancy, which PCOS can make more challenging, but also those that are just seeking management of their symptoms, support for their symptoms, or just a better understanding of what PCOS means, what it means throughout the lifespan, not just the reproductive years, and how you can continue to manage this condition. And because of the COVID situation, we've actually been doing this now by telemedicine, which is great. Tracy is again in our Spokane office. I'm based in our Kirkland office, although I worked at SRM for over 13 years, so I've been based in Seattle, Bellevue, kind of all over. But now that we've been doing this by telemedicine, we've been able to have consults with people throughout the state. So it's made it really easy for us to connect. And we usually do a long first visit to really go in depth into your history, what your symptoms are, what your goals are. And then we're going to do some testing, and then we'll do at least one follow-up visit, sometimes up to 6 visits. So we're doing kind of follow-up visits as needed until you feel like you have a good understanding of what your plan should be moving forward. The challenge with PCOS is there is not a quick fix. There is not the magic pill we're going to give you and then your PCOS is all managed. It's really about getting a lifestyle plan set up, and we want to help you so that you feel like you know what you need to manage those goals. Next slide, please. So some of our patients that we're seeing in the wellness program have already been established patients at SRM. Just because someone's been pursuing fertility treatment doesn't mean they couldn't use some extra support in terms of managing those symptoms of PCOS. And in that case, the nurse practitioners like myself and Tracy are going to kind of co-manage with one of our physicians. So for example, we do have patients who are doing IVF cycles, haven't yet had success, and we know that trying to get your body in the best, healthiest state possible is also going to improve those goals for not only getting pregnant, but having a healthy pregnancy. And so everyone can benefit from best management of PCOS. A lot of our patients are coming to us as the first step. So they're either self-referred, you can call on your own and make that visit, or they might be referred by one of our local OBGYN or primary care providers. And in that case, we're basically your main source of contact. We're going to work with you on those goals. We're going to manage the initial fertility care for those that are trying to get pregnant. And again, we're not going into that today. We will talk more about that in some of the later sessions. But many women with PCOS are going to be able to conceive either on their own or with what we call low technology fertility treatment. Most of what people need is some assistance getting the body to regularly ovulate, and that's something that we're going to work together on. However, if someone either doesn't conceive with that low tech treatment, or if their situation becomes more complicated, then certainly it's really easy for us to internally refer you to one of our REI, one of our reproductive endocrinology and fertility specialists. And I have definitely done this in many situations. You know, I feel like sometimes there's this misdiagnosis of PCOS. PCOS is a diagnosis of exclusion. We need to know that there's not anything else going on. And I've definitely had people self-refer who just assume that they must have PCOS because when they stop birth control, they stop getting periods. And actually, sometimes they have another condition going on. And we want to kind of really first make sure that PCOS really is the most likely diagnosis, as well as then make a plan from that point moving forward. Next slide, please. So the point of having this program based with the nurse practitioners is that the whole philosophy of nurse practitioner care is that you're coming from a wellness model rather than a disease model. We really want to treat the whole person. We want to realize that health is a concept that relates to everything we're doing in our life. So that's why we have a long initial consult. That's why we have a lot of paperwork and a lot of surveys we're going to have you fill out. We really want to kind of go deep into what you're doing for your lifestyle. So to get to that diagnosis, we really want to assess well stress and diet and hormones, medications, exercise, toxins. You know, we want to kind of really take that deep dive, and that's what's going to guide our goals for treatment. We're going to have a strong focus on nutrition. We'll talk about it, and we also really encourage referrals for people that want more support with an actual nutritionist or dietitian. We're going to give you a lot of resources. Exercise is a key component. And again, we have later sessions that are going into more detail about all of these things, including emotional health. I'm going to be speaking at that session in a couple weeks, but we want to keep that holistic approach in mind. Next slide, please. And that's because PCOS is complicated. So quick dive here into the pathophysiology. We know that there is a genetic component to PCOS. Often when you're taking a history, you'll find out that someone's mother or sister or other people in the family have usually struggled with similar issues. Often it's historical and people don't know why. They mention, oh yeah, you know, grandma only had 2 kids. People have these family histories often that are suggestive of PCOS, even if it wasn't really being diagnosed back in the day. We also know that there's a lifestyle component that feeds in. We're learning more now about epigenetics and how the environment, even in the womb, can influence expression of certain conditions. But because of a genetic and environmental risks, you end up with these hormonal changes that are key to PCOS. And the main things that we see is that you have an issue with increased androgens, and that's what we usually think of as the male hormones. And these increased male hormones lead to some of the symptoms that are most bothersome, which can be hirsutism, which is excess hair, often hair in what might be thought of as male patterns, where you have facial hair or chest hair. Also leads to increased acne. On the other side, you usually have some degree of insulin resistance, and about 50 to 70% of women with PCOS are going to have insulin resistance. Now, there's a strong association with insulin resistance and obesity, but many women fall into the category where what they would usually in the past have called a lean PCOS. Now we realize there are many, many body types, but even those that don't express obesity still often have some degree of insulin resistance going on at that cellular level. And that's why we really want to talk about PCOS and management as a lifespan condition. A lot of people focus primarily on the fertility goals, but as women age, that's when often these insulin resistant pieces become even more of a factor. You have a 5 to 10-fold higher lifetime risk of developing diabetes. You have a higher risk of eventually developing cardiovascular issues, narrowing of the arteries, high blood pressure, eventually something called metabolic syndrome, where you have a constellation of these symptoms together. And so the sooner you start trying to manage your condition with healthy lifestyle, the better success you're going to have as you get older. For all of us, I'm in my 40s now, your metabolism changes as you get older, and all the healthy lifestyle things that we're going to talk about, they just get harder to do as you're older. So I encourage anyone that's aware of having PCOS to really get a plan going now, because it's really going to help you in the the future. And many people, if they're coming to see us, it's primarily to address this middle column, that because of these elevated androgens and insulin resistance, you can end up with issues ovulating. The ovaries just don't always recruit a follicle to release an egg each month, and Tracy's going to talk more about what that means. And these irregular cycles are often the key that many women then experience that leads to diagnosis of PCOS. But all these things feed back together to images of body image, self-esteem, depression, anxiety. So this is a multifactorial condition that's going to affect you in many different ways throughout your life, but it also means it's something that you can manage with an approach in many different areas. I'm going to turn it back over to Tracy now to talk more about diagnosis and what happens next.
Perfect. Thanks, Anne. So the diagnostic guidelines that are most widely accepted for PCOS come from what we call the Rotterdam criteria. So to have a diagnosis of PCOS, the patient really just has to have 2 out of these 3 things listed here. The first is just like what Anne was talking about, the elevated androgen levels, meaning the male hormones, and primarily testosterone is kind of the main one that we think about, but there are others as well. And the patient can meet this criteria by either having blood work done that shows that those levels are elevated, or simply from telling us that they have signs of the elevated androgens, like the excess hair growth and the other symptoms that Anne was talking about. The second criteria is irregular menstrual cycles. So mainly if the individual is skipping periods, going months and months between periods, or isn't getting them all together, then that can be a sign that they're not ovulating regularly. And so that can be that's that second criteria. The third one would be an ultrasound showing that the ovaries have a polycystic appearance, kind of like what you see here in this picture on this slide. So again, the patient really just has to have 2 out of those 3 things to have a diagnosis of PCOS. Next slide, please. So how do we evaluate for this condition and where do we start? So like Anne said, sometimes the patients are going to come to us already having a diagnosis of PCOS, but sometimes they come to us just by referral with a suspicion that they could have it. And so we're kind of starting from the beginning, doing the full evaluation. And again, like she had said, this really is a diagnosis that comes from getting a good history from the patient. So what are their cycles like, and what kinds of signs and symptoms do they have? And then secondly, ruling out other conditions that could have similar signs and symptoms of PCOS. So for example, the testosterone and DHEA, the blood work there, so those are the male hormones that we keep referring to. Those can be elevated in PCOS, but they can also be extremely elevated if there are other underlying issues going on. So we kind of check those for sort of a twofold reason. And then the next one's the 17-OHP, that stands for hydroxyprogesterone. And then the prolactin and the TSH, those are the hormones that we check also to rule out that there's any other underlying issues going on. So we want to make sure there's not a thyroid issue or anything else happening there. And then the other remaining labs here, so the hemoglobin A1C, the cholesterol levels, and the vitamin D, we know that people with PCOS can have a higher risk for different conditions like diabetes, high cholesterol, and even low vitamin D levels, actually. And so we check those more just to sort of get a baseline and see where the patient is at, and then we continue to monitor those over time. Next slide, please. Okay. So as we've mentioned, the goal of this wellness program that we're putting on is really to help the patient with all aspects of PCOS. So it's pretty commonly known that one of the features can be irregular periods. So that's something that we can help with. And then what I think many people don't realize is that there are all of these other health implications that are really important to address as well. So we know that women with PCOS are also at risk for developing all of these other things listed here. So I mentioned the diabetes, high cholesterol, but also things like sleep disturbances. Particularly, we worry about sleep apnea. Endometrial cancer is kind of the big one that we worry about. And then also mental health, so anxiety and depression. So what we can do is provide education on those risks, how to monitor and screen for them over time, when to seek evaluation, and then how you can actually decrease those risks. Okay, perfect. So as it states here, the first line treatment to hopefully decrease all of those health risks is really simple. It's really just making a commitment to living a healthy lifestyle. So again, as part of our program, the nurse practitioner will work with the patient on whatever their goals might be, such as improving or working on all of these things listed here. So part of what we do during these appointments is we try to find out what the patient's priorities are and what their goals are. So we help them to set a few goals, and then we plan to have a follow-up appointment, usually in about 2 to 3 months, to kind of check in and see where else we can help the patient. So next slide, please. And then in addition to the patient's goals, the long-term management that we also think about from the medical side of things should also be focused on menstrual cycle regulation and prevention of the complications that we just reviewed. So here at SRM, we can offer, a wealth of information and get the patient on the right track towards their goals, but we do really stress that the management of PCOS really does take a team. So, we can provide referrals to other specialties if needed, such as a dietitian, a nutritionist, or a counselor, or whatever that patient might need. And then additionally, we, of course, always encourage every patient to get established with a primary care provider for long-term management as well. So next slide, please. So that is the end of our content, and then Anna is going to wrap up for us.
Yeah, thank you so much, Tracy. Again, today's kind of a weird talk because it's mostly just trying to get you interested in the rest of the topics that we're going to be discussing. So remember, we want you to come back every Thursday for this month. It's kind of funny because April is Easter. We think about eggs. Let's think about PCOS. But we're talking about next Thursday going more into nutrition, which is key. Food is medicine, and what we feed our bodies is really in many ways even more important than when we're talking about the medication prescriptions that we could be using for PCOS. The next week, we're going to be talking about exercise and lifestyle factors. And then I'll be back on the 22nd, along with Jamie, one of our great mental health counselors, to talk about anxiety, depression, disordered eating. And finally, on April 29th, there'll be more of a dive into what's involved with treatment and fertility. Marcy or so, do you know, there's a question here about how we charge for the appointments and out-of-state patients? I know from my experience with the charging, most of the time we're trying to use the diagnosis codes that are related to PCOS, as well as the coding that's related to any conditions that we're going to manage. So if we did discover that someone had levels that put them at the range for prediabetes, we're going to try and use whatever medical billing codes apply to hopefully increase coverage. But the costs are by time, and if you have questions about whether your insurance covers visits, we also have financial counselors, and so you can call, talk with one of the financial counselors. They can talk in more detail about your benefits. But that's what's been nice about COVID is most major insurance plans are now allowing for these telehealth visits to be covered, where they didn't used to be. It used to be if you came in person, it was covered, but phone and video was not. And at least for now, people have been allowing coverage even with these telemedicine visits. I just got a message from someone on the organization team saying that, yes, usually we can bill to insurance as long as we're an in-network provider. So it's always good for you to talk to your insurance directly. But we are billing basically by time and with whatever the appropriate diagnosis codes are. Let's see, I was thinking too, Tracy, we forgot to mention that PCOS is incredibly common. Rates range from sort of 6 to 10, even up to 12% of the population. And you think about the high rate of people this is affecting and the low rate of awareness and research that's really been done compared to other health conditions. And it's pretty kind of shocking. But I think that there is an increased awareness. And I hope that some of the people that are attending today are medical providers as well, who are aware of the fact that this is a condition that really needs a multidisciplinary approach. And our goal is not to manage everything. Our goal is to really help the patient figure out what their top goals are and how can they achieve that with kind of that team approach. And anyone that's interested in scheduling a visit, this number here is at the bottom in terms of how to get a hold of us. We're also glad to answer other logistical questions about the program if you have them. I thought it's kind of interesting to mention, I'm getting ready to do another talk about this for a symposium that we have coming up in May. And I was looking at our data because we've been tracking the visits that the nurse practitioners have been doing. And this is a fairly new program. We launched it last fall, but we've already had almost 60 visits spread amongst the nurse practitioners. And out of those, about 70% of the people are seeking pregnancy, but about 30% are not. And that's kind of what I would have ballparked. You know, PCOS is a condition that really does have a lot of important management needs outside of trying to get pregnant. I think it's great that we have that much interest in people that are trying to figure out how to manage outside of those reproductive concerns that we usually think of. Let's see. So we have another patient. I have a patient who had no issues conceiving, another question, who had no issues conceiving in her early 20s, but now in her later 30s, she has elevated testosterone levels and typical PCOS symptoms. Is it common for symptoms in labs to not show until later? You know, I wouldn't say it's super common. Actually, what you see a little more commonly is sometimes the reverse pattern. You have people that had a lot of issues with irregular cycles in their 20s, 30s, and suddenly when they're 42, 43, they start having regular periods again because that egg supply has continued to go down and now their ovaries function more normally. But sometimes, I mean, everything is different. And even women with PCOS who have irregular cycles still often ovulate sometimes. And so that's one of the other main things that I stress to people is that PCOS is not birth control. Someone who does not want to get pregnant still needs to be on contraception, because we definitely have women with PCOS that just assume they can't get pregnant because their cycles are kind of all over the place, and definitely do. So just because someone has conceived easily in the past doesn't mean that they couldn't have PCOS, but we'd certainly want to do the full workup to make sure there isn't something else going on, especially when someone presents with a slightly more atypical pattern like that. Most of the patients that we see tend to be in their sort of mid-20s to early 30s, just because that's often that age range where most people are now trying to conceive. Usually when people are younger, their symptoms are just going to be managed by putting them on birth control. I mean, that really is kind of the first line treatment, and that works great until you're ready to get pregnant. And suddenly you can't use birth control to manage your PCOS and get pregnant. Any other questions? Oh, let's see. Someone said, I've heard that PCOS women may have a better chance to get pregnant in their mid-30s or earlier. Do you ever suggest women wait? Is that information incorrect? So I would say that question goes along with what I just said, that, you know, if you think about the normal process of ovarian aging, women are born with all the eggs they're ever going to have, and that supply starts to go down in your late 20s, and then that curve gets even steeper after the mid-30s. And because women with PCOS often have a higher number of eggs on the ovaries, that's part of the reason it's a little harder for them to pick when to ovulate, and they'll go into more of this in the last session. As they get older and that supply plummets, they can get more regular cycles, but it is still definitely going to be better to try and conceive earlier because of the egg quality issue. So as we get older, the number of eggs goes down, but the quality of that eggs goes down even more significantly, and that's often the key factor. So we would definitely not suggest someone delay childbearing until they hit later in their 30s. If they're ready to try now, there are a lot of hopefully fairly low-tech treatments that can help those with PCOS conceive. Do you want to take any of these other questions, Tracy?
Sure. So it looks like there's a question, is the only way PCOS affects fertility via anovulation? So, you know, the irregularity with ovulation is definitely, you know, kind of the big one that we think about that can make it difficult to conceive. But there are other factors as well. So, you know, just like we talked about, this condition really is multifactorial and affects so many different body systems. And so, you know, there has been research that shows that low vitamin D levels, you know, can be associated with difficulty conceiving and insulin resistance and those things. And so kind of some of those other components that go along with PCOS can affect, you know, fertility as well. But anovulation is definitely the big one, I would say.
And then someone was asking about, are we going to talk more about lean PCOS? Not specifically in these talks. It is a fairly significant subset of the population, though. Historically, if you look online, these diagrams seem to show somebody having every single possible symptom, but some estimates say up to 30% of those with PCOS are going to not express what's thought of as that typical body type in terms of excess body weight. But basically, if you're coming in for treatment, we would talk more about you specifically and kind of where that plays in. And the main thing to know about that is that having potentially the leaner body type still does not prevent those potential metabolic complications. That's the interesting thing. The chances are lower because we know that independently, excess weight certainly increases the risk of things like diabetes in the future. But even those that are not expressing their PCOS in that way still have a higher rate of insulin resistance than the general population that's at a similar matched BMI. So there's something going on at the genetic or cellular level with PCOS that we don't completely understand yet, because we know that we do see higher risks of insulin resistance, even those that are not also struggling with obesity. Someone else asked about being on birth control pills for management of PCOS if they're not ready to conceive. Yeah, exactly. For a lot of people, that really is going to be that frontline treatment. And I think a lot of our education when we have people that are now struggling to conceive is making sure they know that that was not a bad decision. I have a lot of people that are like, my cycles were always so regular when I was on the pill, and now that I'm off the pill, they've gone away. And so explaining that that was the whole point of the pill. When you're not on the pill, when you're on the pill, that kind of steady state hormones is protecting your uterus from that increased thickening that can happen if you don't have regular periods on your own. That's keeping that risk of endometrial cancer low that Tracy mentioned. Having that consistent low level often helps decrease the side effects of excess androgen. So birth control pills for many women are a great treatment. They're kind of the frontline treatment. And many people do just stay on them until they're ready to try and get pregnant. I know sometimes there's this myth that you should have this washout period and go off the pill months before you're trying to get ready. That's really not something that we see supported by literature. And some women might conceive very quickly when they go off the pill. So you don't want to go off the pill before you're actually ready to try and get pregnant.
And then it looks like somebody asked with IVF, is there more of a risk for OHSS with PCOS? So that's a great question. OHSS, that's Ovarian Hyperstimulation Syndrome. So PCOS, yes, can be a risk factor for developing OHSS. But there are multiple other risk factors as well that we kind of take into account. And so the physician will really look closely at those risk factors and take that into account when they're developing the treatment plan for the patient to try to decrease those risks as much as possible. But yes, PCOS can be a risk factor for OHSS.
And because we've gotten just so much better over the last few years at preventing OHSS, the combination of medications we can use now to cause final maturation of the eggs, but in a way that clears the body much more quickly. Usually women with PCOS, if they have to pursue IVF, are going to break that process up into 2 cycles. One cycle where they grow that batch of eggs, and because they have PCOS, they often grow a high number of eggs, and then we would fertilize those eggs, freeze those embryos, let their body recover from the stimulation, and then do a cycle where we actually put an embryo in the body to get pregnant. And being able to do a cycle that way means that even if your ovaries are kind of big and stimulated with OHSS, and those that aren't fertility, that just means ovarian hyperstimulation, just you grew a lot of eggs, and if you have PCOS, you have a lot of eggs, so that's a high chance of happening. But by freezing the embryos after the egg retrieval and letting the body recover, instead of transferring one and getting pregnant all in one go, the chances of developing serious complications from OHSS are extremely low. It is a self-limiting condition as long as you don't get pregnant. And that was the issue back in olden times IVF, is that often if you have PCOS, you're often a good prognosis for IVF because you tend to get a lot of eggs, and that hopefully gives us a good, maybe higher than expected number of embryos, although not for everybody. Everybody's supply and quality is going to be different. And it was really people getting pregnant in the midst of an IVF cycle when those ovaries don't have a chance to really return to their normal size that you often would be more bothered with OHSS. These last couple questions, someone asked about the first step to addressing anovulation. It's a great question, so definitely tune in on April 29th when we talk about treatment and fertility. And talking about increased chances of twins, even with low-tech treatment, yeah, definitely. Because if we're trying to get ovaries to ovulate that aren't doing it on their own, there is a higher chance that even though we try and go slow with medications, those ovaries might pop out 2 eggs instead of 1. And so that's one of the things that we always have to address when we talk about the pros, cons of fertility medication. And a lot of people are going to want to start with the lowest intervention possible. And that's why we really do try and take that holistic approach, especially for those that are overweight. Losing even 5 to 10% of body weight, for many women, that's enough to restore ovulation. So medications are not usually the very first step. They are often a step that we get to, but sometimes we can get ovulation restored with lifestyle change, with some certain supplements, a few other medications that help your body manage insulin resistance in a better way. So we really try and take that individual approach. I think we're getting to the very end here. Tracy, is there anything else you want? That last question, you want to take that one on hyperandrogenism?
Yeah, I was going to ask what you tend to see. I feel like I do see that does improve. What do you think, Anne?
I feel like I see both. I think it's the hard part. It's like everybody's different. You know, when we talk about women that have migraines, when they get pregnant, about a third have resolution, a third have worse, and the third stay the same. I feel like it's kind of the same for hyperandrogenism. It's certainly some women feel that those symptoms improve. Some women are like, oh my God, I've never broken out this much in my life. So it's unfortunately not something I would say is for sure going to be better, but I would say most women are so happy to be at that point. And right now it's COVID. You're not going out. No one's going to see you anyway.
Right.
Yeah, exactly. Someone else made the same comment. In her experience, the symptoms usually stayed the same. Side effects of pregnancy are similar. Yeah, exactly. Pregnancy itself, it's kind of a myth that you have that beautiful pregnant glow. Many women, even without PCOS, instead have total breakouts, especially first trimester. So someone else asked about inositol. Yes, we are. So that'll be one of the things that we talk about when we get into more of treatment and management. So anyway, I don't want to keep people too long because I know we wanted to make this kind of short and sweet. And as you can tell, there's a lot more that we're going to talk about. So I'm really glad that you guys could come here. And I hope that you tune back in for next week when we go into more detail about exercise and lifestyle and then mental health. And then finally that last week, we'll get a little bit more into treatment. But if you are tired of just having general talks and want to talk more about you specifically, you don't have to wait for the whole series to schedule a visit. You can always call that number if you want to just be able to have that long visits focusing on your specific concerns. Thanks so much, everybody. We're going to be giving a survey, and we would definitely love your feedback. So look for that, and hope to see you again next week. Same time, same Zoom login. Come with your questions. Thanks so much.
Yeah, thanks, everyone.